Hello all, this is Dr. Rup Kumar. Welcome back to another masterclass series from Dentospedia. Today we are dealing with the 7th session of oral radiology, and today's topic is about investigations for salivary gland pathology. In this session we are going to discuss mainly about salivary glands like parotid gland and submandibular gland. Okay, and these are the list of investigations which we commonly prescribe for the patient with the salivary gland disorder. They are plain radiographic examination, commonly called as plain X-ray. Okay, sialography, which is a kind of invasive procedure, CT scan, radioisotope imaging, flow rate studies, ultrasound, and MRI scanning if necessary. Okay, and coming to the first investigation, that is plain X-ray. A large proportion of salivary gland calculus are radio opaque in nature. Okay, they appear white in radiographs, approximately 40 to 60% in parotid and 80% in submandibular glands are radio opaque stones. And when we are comparing parotid and submandibular glands, the stone formation is common in submandibular glands because the ducts, the nature of the ducts and the path of the submandibular gland duct, and also the viscosity of the saliva produced by the submandibular gland is more viscous than parotid. So because of these reasons, we can see more calculus formation in submandibular gland when compared to parotid. Okay, and if there is any large stone formation, it can result in acute intermittent swelling of that area. Okay, and plain X-ray is a common investigation for diagnosing calculus. Okay, and here you can see this is an example of a submandibular gland stone. This is a part of an OPG. Here you can see the major distal width of the calculus, but you can't get the buccolingual size of the stone. And then we use the right angle technique. So we are exposing the patient for another time by taking occlusal radiograph. By taking this radiograph, we can get the buccolingual size of the stone and also its accurate position, right? So this is the right angle technique which we have discussed in object localization chapter. Okay, and coming to the next investigation, that is sialography. It is a kind of invasive technique. Okay, this is a radiographic demonstration of major salivary glands and its ducts by introducing a radio opaque contrast medium into the ductal system. So sialography is nothing but, in sialography we insert certain contrast medium into the salivary glands so that it can illuminate the tissue. Okay, and then we expose X-rays, and because of the contrast medium is radio opaque in nature, we can see the salivary glands well in the radiographs. Okay, usually the soft tissues are not visible in X-rays, right? So usually the plain X-rays are meant for hard tissues, but how we are able to use for salivary gland disorders? So that's why we are inserting a contrast medium into the salivary gland ducts and also the gland so that it can illuminate from inside, and then we expose the patient for the X-rays, and then in the radiograph we can see the salivary glands with the help of contrast medium. So that's the whole procedure. Okay, and this procedure is divided into 3 phases: preoperative phase, filling phase, and emptying phase. So here in this slide you can see usually these glands or ducts, these are radiolucent in plain X-rays, so we can't get images with the help of X-rays. And then we insert the dye, we inject the dye contrast medium into the ducts. It can illuminate the structures, and then if we expose X-rays, expose the tissues with X-rays, it can result in image formation. So the contrast medium illuminates itself within the structure. Okay, so that's the idea of using contrast medium. So what is preoperative phase? It is the first phase. Okay, and this involves scout radiographs. Okay, and in the first phase we expose the patient with without contrast medium, and these radiographs are called preoperative radiographs, also called scout radiographs. Okay, and what is the purpose of taking these scout radiographs? To note the position or presence of any radiopaque obstruction. Suppose even though we can't see the salivary gland structures, we can see the calculus, right? So that's why we are taking the scout radiographs. To assess the position of shadow cast by any normal structures which may overlie the gland, such as hyoid bone. Sometimes in our anatomical structures, one structure might superimpose on other, and it can hamper the diagnosis. So usually we check out for these any superimpositions by taking scout radiographs, and also to assess the exposure factors. So the exposure factors like kilovoltage peaks, right, and also milliamperage and exposure settings. These are the three important settings which you have to control during the exposure. So we have to maintain optimal settings to give uh, so that the radiographs will be of optimal radio density. Okay, we don't want any overexposure or underexposure. So that's why we're taking scout radiographs. And these are the common radiographic projections used for salivary gland disorders. And for parotid gland, we commonly use panoramic radiograph, oblique lateral, rotated posterior anterior or anterior posterior radiograph, and intraoral view of the cheek. For submandibular gland, panoramic radiograph, that is OPG, oblique lateral can be used, lower 90 can be used, occlusal, it is a type of occlusal radiograph, lower oblique occlusal radiograph can be used, true lateral skull view with tongue depressed. Okay, these are the views, or these are the projections which we can use based on the type of gland. Okay. Coming to the next phase, that is filling phase. So we have taken the scout films, right? And then the main process starts. We inject the contrast medium into the salivary gland ducts. Okay. And how we will inject? We first locate the orifice. Either it is parotid or submandibular gland. We locate the orifice first, and then we have to probe it and dilate it. And then we cannulate it. We inject the contrast medium. So that's the process. So the contrast medium then can be introduced. So with this, the filling phase has been taken, and then we take radiographs. Okay, at least two different angles, right angle to each other. So this is about filling phase. So in this phase, we have injected the contrast medium, and then we take the X-rays after injection. And coming to the third phase, that is emptying phase, the cannula is removed and the patient is allowed to rinse out. The use of lemon juice at this stage to aid in excretion of contrast medium is often advocated but seldom necessary. After 1 to 5 minutes, the emptying phase radiographs are taken, usually oblique laterals, and these films can be used as a crude assessment of function. So in this phase, we are emptying the salivary gland. Okay, we have to remove the contrast medium, right? We can't live like that. Okay, so usually the contrast medium will be ejected out with the help of salivation, excessive salivation. Sometimes in few cases salivation might not occur. In those cases we can use lemon juice as a trigger. Okay, and after the emptying phase, and then we go for radiographs. Usually oblique laterals is common radiographic technique which we commonly use in this phase, and then we compare these three radiographs. First, in the first phase we have taken the radiographs, right, and then in the second phase we have taken one set of radiographs, and then in the third phase we have taken another set. So we compare these three radiographs, and then we assess the glandular function and the position of the stone, right? All these can be assessed. So what about the contrast media? So there are mainly two kinds of contrast media, iodine based and non-iodine based. In the iodine based we have mainly two kinds, aqueous and non-aqueous. Non-aqueous is also called oil based. Okay, and in the aqueous based contrast media we have two kinds, ionic and non-ionic. So this classification is kind of important. You make sure that you learn it. And these are the examples of contrast media. For ionic aqueous solutions, the main composition is diatrazate, that's the chemical name. Urographene is a brand name. Metrazate is a that's a contrast medium composition. Okay, triazole is a brand name. And coming to the non-aqueous solutions, iohexol is the main thing. and Omnipaque is a radio, that is a brand name. Okay, and coming to oil-based solutions, we have iodized oil. Example, Lipidiol is a brand name where iodized oil is used. Okay, iodized poppy seed oil is used. And water insoluble inorganic organic compounds, inorganic iodine compounds is used in a brand called Pantopaque. So you must remember these contrast media, and also if possible remember the brand names. Okay, and most of the radiology departments use aqueous solutions. Since the contrast medium is not being introduced into the bloodstream, there is no need to use the safer and also more expensive non-iodinated contrast media. So when compared with the aqueous, and when we are comparing aqueous and non-aqueous solutions, non-aqueous based contrast media, usually aqueous based is commonly used. Okay, and they're kind of cheaper when compared to oil based. Okay, and they have their own advantages and disadvantages, right? We'll discuss further. And what are the advantages and disadvantages of oil based and aqueous solutions? So the coming to advantages of oil based, it is densely radio opaque, right? And it can show good radio contrast, and it has high viscosity and thus slow excretion from the gland. So even though it is kind of high viscosity, it has its own advantages because it is highly radio opaque. So we can clearly see the structure of the salivary glands from within the, because of the contrast media, and provides good contrast. What are the disadvantages? Extravasated, during the emptying phase, we have to eject out the contrast media, right? So in oil-based, the oil-based contrast media might not evacuate from the salivary gland duct as you expected, right? Because it is of high viscosity, we can't remove completely from the duct, and it might produce foreign body reaction. Okay, and also we might face a difficulty during injecting the contrast medium because it is highly viscous in nature. We have to apply high pressure to introduce the contrast medium into the duct. Okay, and calculus may be forced down into the main duct. For example, this is orifice and this is a glandular duct, and you are suspecting there is a stone here. Okay, and then you are injecting oil-based contrast media because you need greater contrast. But the disadvantage is when we are using high viscous oil-based media, we have to inject with high pressure. So because of the high pressure, this stone might they get into deeper, even though it is superficial at the present. Because of the injection of the contrast media, the stone might get dislodged deeply. So we are complicating the case. Okay, so they have their own advantages and disadvantages. Coming to aqueous based, the advantages are low viscosity when compared to oil based. It can be easily introduced and it can be easily removed from the gland. Okay, and gets easily absorbed if excreted, extravasate. So these are the kind of advantages. Mainly, the main important points are aqueous based solutions have low viscosity, it can be easily introduced, and it can be easily evacuated. And coming to the disadvantages, it provides less radio opaque radio densities. So comparing radio opaqueness between oil based and aqueous solutions, oil based give more radio opaque to the images, and aqueous based gives less radio opaque for the images, and also less contrast can be expected because there is less radio opaqueness in the images, right? And excretion from the gland is very rapid unless we use a closed system. We have discussed, right? It can be easily introduced and easily evacuated. So easily evacuation is also kind of a disadvantage, right? It has to be, it has to maintain certain duration so that we can take radiographs. So there will be certain duration around 5 to 10 minutes. So because of we are using aqueous solutions, it can be easily excreted. So that's an advantage. that is both advantage and disadvantage. Okay. And coming to the main indications of sialography, it is mainly used to determine the presence and position of the calculus or any blockages, to assess the extent of glandular and ductal destruction secondary to any obstruction. Suppose if there is any chronic obstruction, we might see certain damage in the glandular tissue. To determine any extent of glandular breakdown as a crude assessment function in cases of dry mouth. For example, in xerostomia cases, we can see dry mouth. In those cases, we can expect certain glandular damage, right? And also to determine the location and size of a swelling or any mass, like tumors, right? We can diagnose these kind of disorders with the help of sialography. And coming to the main contraindications, where should we not use the sialography? If the patient has any allergy to the compounds containing iodine, in those patients we have to be very careful and not to use the sialography. Okay. And any previous infections or inflammation regarding the salivary glands or any discharge from the salivary glands, we might not use this technique in those cases for diagnosing. Okay. And also, if the calculus is present close to the ductal opening, if we use this technique, we are complicating the case. We have explained it, right? If the stone is present near the orifice, we don't want to use this kind of technique, because if we inject the contrast medium, the stone might insert, they might progress towards deep into the salivary gland, and we are complicating the case. So that's why in those cases where the calculus is close to the ductal opening, we don't use this kind of investigation. Okay. And what are the normal sialographic appearances of different glands? Okay. And coming to the normal sialographic appearance of parotid gland, it is called tree in winter appearance. Okay. So tree in winter appearance is an important MCQ. So the gland will look like this if the contrast medium is injected. Okay. And coming to the normal sialographic appearance of submandibular gland, it is called bush in winter appearance. So this is the sialographic appearance. You can see the contrast media, and it will lighten up the gland. Okay. This is an important MCQ. And what do we observe? What are the conditions where we use sialographic technique as an investigation to diagnose if there are any ductal changes associated with the disorder? Suppose calculi or sialodenitis. In these cases, we can use sialography. Okay. Sialodenitis is nothing but ductal inflammation or any infection. And if you suspect glandular changes in the salivary gland, we can use this technique. These are the common cases where we can see glandular changes occurring because of the pathology. That is sialadenitis. It is nothing but glandular inflammation and infection. Sjogren's syndrome, intrinsic tumors. So these are the conditions where you can see glandular changes. And we'll learn about the sialographic appearance one by one. And coming to the appearance of calculi in sialography. Here you can see in certain situations, this filling defect can be seen. Suppose this is the duct. Okay. Here there is a salivary gland stone. So if you are injecting the contrast media, and it will not the contrast media will not go further beyond the stone, right? So if you take radiograph, the contrast medium will be present here but not here. That is called filling defect. Okay. And ductal dilation proximal to the calculus. Suppose if the salivary gland stone is much bigger than the normal size, okay, and because we are injecting the contrast media, it might dilate the salivary gland duct proximal to the stone, and this kind of appearance also gives a clue for salivary gland stones. Okay. And emptying film shows contrast medium retained within the stone. Suppose somehow the contrast medium has reached the gland, okay, bypassed the stone and reached the gland. and then we take radiograph, right, after during the emptying phase. So this, the contrast medium present within, in the proximal region, it will empty out easily, but the contrast medium present within the gland will be trapped inside. Okay, so when we take the emptying radiographs, we can see the retaining contrast medium within the gland. Okay, so these are all the appearances where you can suspect salivary gland stones. Here you can see the filling defect. This is the gland. There is a stone here. So because of the presence of stone, there is no illumination of the gland with the contrast medium. The stone is stopping the contrast medium to reach the gland. So that is called filling defect, and also you can see the dilation of the duct. Right, this is not the normal size of the duct because we are injecting the contrast medium in presence of stone. There is a proximal dilation of duct. So these two indicate, there is a stone in the duct. Okay, here you can see the medium retained in the parasitic gland. So this is a glandular duct. So during the evacuation process, there is a stone here, right? So during the evacuation process, the contrast medium will be easily evacuated. This portion of the gland will be cleaned out, and because of the presence of stone, the contrast medium here will not get evacuated. The stone is obstructing the pathway. So that's why you can see a medium retained in the behind the stone. Okay, these are all appearances of calculus. And coming to the sialographic appearance of sialolithiasis, it is nothing but inflammation of the glandular duct. So the appearance is called sausage link appearance, and it is mainly this appearance is mainly due to segmented circulation and dilation of the main duct. Okay, you can see because of the presence of stone and because of presence of inflammation, the glandular structure might be segmented with certain dilation and strictures, right? And this is called sausage link appearance, which we will see in sialolithiasis. And coming to the sialographic appearance of sialadenitis, it is nothing but inflammation of the gland itself. Okay, and this appearance is called sialectasis. So don't confuse between sialadenitis and sialectasis. Sialadenitis is a condition, pathology, but sialectasis is an appearance, the name of the appearance. Okay, what do you mean by sialectasis? So it is nothing but dots or blobs, tiny dots of contrast medium within the gland. Okay, and the duct is usually normal. So here the inflammation lies in the gland, right? So the duct will be free of inflammation, and the duct will be normal in radiographs. And in the gland, you can see the inflammation, and because of the inflammation, there will be dots of contrast media within the gland. So that appearance is called sialectasis. You can see these tiny dots within the gland. That appearance is called sialectasis. And coming to the sialographic appearances of Sjogren's syndrome. So in Sjogren's syndrome, xerostomia is one of the characteristic feature. Okay, and in that syndrome, we have a particular appearance called punctate sialectasis or snowstorm appearance. So sialectasis, and don't confuse in between sialectasis and punctate sialectasis. These two are completely different. Okay, sialectasis we see in sialadenitis condition. Okay, and punctate sialectasis is seen in Sjogren's syndrome, and this appearance is also called snowstorm appearance. And here also usually the duct will be normal. So what is the main difference between punctate sialectasis and normal sialectasis? So usually the size of the blebs, here you can see the punctate sialectasis is a kind of a larger dots when compared to normal sialectasis pattern, right? And how do we get this pattern? Usually in Sjogren's syndrome, the contrast medium will be leaked out into the extravascular space, right? And there will be tiny dots. But here in sialadenitis, there is no leakage of contrast medium into the extravascular tissue, right? And also, because of the inflammation, the glandular acinus is kind of dilated, right? And this gives an appearance of a large blob, large dots. So both appearances, the common thing is sialectasis, that is called dots or blebs of contrast medium, but the size matters. Here in Sjogren's syndrome, you can see tiny dots, right, because of extravasation of contrast medium. But in sialadenitis, you can see single large dots or blebs of contrast medium. So that's the main difference. Here you can see the normal sialectasis appearance, the dots are large, right? But here in punctate sialectasis, it is kind of a smaller due to extravasation of contrast medium. So that's the main important difference which you should look out for. Okay. And coming to the sialographic appearance of intrinsic tumors. So tumors can occur in salivary glands, especially a particular tumor called pleomorphic adenoma. This is the most common tumor occurring for the parotid gland. Okay. And that appearance is called ball in hand appearance. You can see here there is a tumor here, right? And when we inject the contrast media does not enter into the tumor, but it enters the salivary gland tissue, right? So the salivary gland tissue is surrounding the tumor and it will illuminate the salivary gland. So it gives an appearance of a ball in hand appearance. So ball represents tumor and hand is represented by the salivary gland surrounding the tumor. Okay, and you can clearly see there is a ball like structure within the hand of salivary gland. Okay, so that's all the sialographic appearances of various disorders. And coming to the interventional sialography, commonly if the salivary gland stone is, if it is smaller, we can easily do minor surgery, we can evacuate the stones. Sometimes if the stones are complicated in position and also its shape, we have to use certain methods called interventional sialography, where we use certain balloon catheters and small Dormia baskets under fluoroscope guidance to remove those stones. Okay, and you can see here you can see there is a stone here at a complex position, right? In these cases you can't easily evacuate the stones, so that's why we use certain instruments called balloon catheters. Here you can see the catheter, right? It can be inflated easily. So when we insert the catheter and then we can capture the stone and then we can remove the stone from the duct. Okay, this is called interventional sialography and it is all done under fluoroscopic guidance. Okay, so that's an important investigation, right? So based on the diagnosis, so based on the clinical situation, we have to select appropriate investigation. And coming to the flow rate studies, it is nothing but they are used to investigate the salivary gland function. Comparative flow rate studies of saliva from major salivary glands are measured over a period of time. So we measure the salivary gland saliva production, and the flow rate of the saliva, and then we assess the glandular function. Okay, and what are the indications of these investigations? Commonly we use it for dry mouth, poor salivary flow and excessive salivation. So in these cases we will use certain investigations like flow rate studies to assess the function. And what are the advantages? Ionizing radiation is not used, it is simple to perform, and it provides information on salivary gland function. So we are not using any contrast media, we are not using any radiographs, x-rays. So it is non-invasive procedure and safe to use. And what are the disadvantages? It provides only limited information and kind of a time consuming. So this is all about flow rate studies. Coming to the ultrasound. So in ultrasound we use certain acoustic waves, right? And what are the indications? It is mainly used for diagnosing discrete and generalized swellings of the salivary glands or any kind of obstruction in the glandular region. Okay, and what are the advantages? We are not using ionizing radiation, right? So we are not using X-rays. It provides good imaging for the superficial masses, for example, tumors, and we can easily differentiate between solid cystic masses, right? And we can differentiate between cysts and tumors. Different echo signals are obtained from different types of tumors, and identification of radiolucent stones. So if the stone is radiolucent, we can't use X-rays, right? So in those cases, we can go for ultrasound and then we can diagnose the condition. Lithotripsy of salivary stones. So lithotripsy is nothing but crushing of stones. Okay, and when we have to do that kind of a procedure, we need a guidance, right? We use ultrasound guidance for lithotripsy. And same kind of technology we use for renal stones. Okay, and then also we use lithotripsy for crushing the stones under ultrasound guidance. And we can use ultrasound for needle biopsy, and we can use small probes to assess the internal structures. And coming to the disadvantages, the sound waves are blocked by the bone, so limiting uh, the areas will be limited. So we can't use for bony, the bone kind of the bones are kind of obstruction to the acoustic waves. So that's why we can't use much, for diagnosis of certain tumors or ultrasound. Suppose if you are suspecting any kind of tumor in mandibular third molar region, especially in the ramus region, and in those cases you can't use ultrasound much because presence of bony structures around it. Okay, and it provides no information regarding the ductal architecture. So that's a major disadvantages, because in cases like calculus we can't use ultrasound because it doesn't give much information. That's the end of the session. We'll meet again in the next masterclass series. Thank you.